Hi. I'm going to be presenting to you work from my home country of Lebanon, exploring healthcare and access to healthcare technology, in specific looking at refugees. So Lebanon's hosting a large number of refugees. There's one refugee to every 4 Lebanese. And what this meant that there are 200,000 Syrian refugees residing in the rural area of Bika, near Zahle, in informal tented settlements. What that means is that it's a plot of land that they have rented out and have set up tents. And the literature in public health has shown that this population is at a higher risk of reproductive health complications, and specifically the refugees in rural Lebanon have been found to have these issues. So when we look at technology, specifically HCI and refugees, we find that we do have a lot of studies looking at the types of phones being used by refugees in both the Western Hemisphere and in the Middle East. There's also a lot of tools, such as the one presented before, looking at language translation, and also how do we aid refugees in navigating within their new environment. Digital storytelling, computer clubs, digital role-playing have all been used also in order to increase intercultural communications and also in order to improve the well-being of refugees. However, that's been more specifically targeted at younger generations of refugees. When we look at also, we can lean on the literature from HCI for development when it comes to maternal and reproductive health. There's a lot on work coming out from India, for example, looking at how do we support social workers by providing them with tools, digital tools, in order for them to engage better in the education sessions. And there's also a lot on providing health education to refugees directly in the form of text messages and SMSs. So with that in mind, we started to look at specifically the context within Lebanon. We did a landscaping exercise for us to understand more what is the health system that they are attempting to access, and also to understand how are the healthcare providers interacting with them. We also then moved to the main bulk of the study, which I'm presenting today, which is an explorative study, looking at how are they using technology, in what context are they using technology, and also what are the new design possibilities and how do they prefer to use technology for their health. So the landscaping exercise actually led us to go to 5 informal tented settlements that the NGOs and the clinics feel that they are not reaching out to appropriately. Each informal tented settlement had around 60 to 70 families, and we conducted 6 focus groups. And it's important to note that in order to access the population, we had to engage with a large number of stakeholders, all the way from the Ministry of Public Health to local NGOs. And also the landscaping exercise informed the focus group schedules, because we were able to then surface in our discussions with the refugees about how often are they going to the clinic, and are they facing communication problems when they are talking to healthcare providers? Because healthcare providers told us they are of low health literacy. They're not understanding us when we're talking to them. And it also surfaced an issue of trust. You'd find that the healthcare providers weren't enthusiastic about using technology with refugees because they said, oh, they wouldn't be able to use technology effectively. So with that in mind, we started going into the field. Before presenting my results, I'd like to, though, just give a setting of how the fieldwork was set up. So we'd go to the informal tented settlement and sit in a tent, which was quite large, and then the women would all sit in a circle around us, around the tent. However, because the women had nowhere to leave their children, that meant that the children were with us in the focus group. So you can imagine how chaotic that was. And it also had a very fluid nature. The woman would leave the focus group in the middle of it to go check on the food that they're cooking. And also, as word spread that we're in the settlement, more women would start coming in. And it's culturally rude to say, sorry, you can't join us. So that meant we'd had to stop the focus groups and then reconsent again. We also took with us ideation artifacts. We made cards, pictorial cards, in order to start leveraging and generating ideas about how do you want to communicate with your healthcare provider. And we also made a booklet that had educational material in it, but also had a recorder. And we wanted to explore, do you want to record how you're feeling? Or do you want the healthcare provider to record what you're prescribed or the health education? And what we found is that there was a big disconnect between the refugees and these artifacts. Firstly, because they didn't want their children to grab at them. So we'd want them to pass it around the tent. The woman would look at it and then put it to the side the moment her child would try to grab at it, because they didn't want to ruin our artifacts. And also, the woman struggled with the idea of generating ideas around technology. One woman told us that We barely think of how to use our phones right now, and you're expecting us to come up with these ideas. It's quite difficult for us. So moving to our main findings. What we found is that they are using mobile phones. Almost every household has a mobile phone. And they are connected to the internet through 3G or Wi-Fi. In every settlement, there's one entrepreneur refugee who set up a router and is selling Wi-Fi to the rest of the community. And mainly they use WhatsApp. Communication is essential for them to communicate with their families and to each other. But when we started going into the usage of WhatsApp, we found out that the population is of low literacy, and therefore they don't text. They send voice notes. And when we discussed why don't you then use WhatsApp call, they said the internet is too slow, and therefore voice notes is the best medium. We also discussed using images and sending images to healthcare providers to help diagnosis. And culturally, the women found that to be inappropriate. They did not want to have images on someone else's phone of themselves. And also, when discussing group messaging, they said that group messaging is overwhelming as a medium of communication. They said that it would be too distracting. One woman said that if I turn around, my daughter would burn the tent down, which has happened before, so it's a valid worry. So we also found, and most importantly, that this finding was dear to my heart, in that these women stick together. They have strong local social networks. They go to each other for health advice. They choose their healthcare provider based on what they've heard from other women. They exchange favors. When one woman goes to a market, her neighbor would take care of the children. However, what we found is that when it comes to health, and specifically more reproductive health, men have no place within that social network. So the women would comfortably talk about all their health issues with each other. The men, even when we were talking to them in the context where the other women were not around, they did not feel comfortable talking about these issues. And so the women told us that the men leave us to take care of our own health in this situation. And another important point is that in every informal tented settlement, there was the sheikha, who's the wise one. She is the woman that everyone seems to go to seek health advice. They trust her, they feel comfortable talking to her, and they do follow her advice. The issue is that she has no type of healthcare expertise or even social working expertise. And so whether the health information being given is correct or not, we can't tell. So then we start looking at how are they accessing healthcare and what's dissuading them from accessing healthcare. And one of the main issues that came up is their negative experiences with the healthcare system. They perceive that healthcare providers are discriminating against them, that healthcare providers are not giving them the appropriate time, and therefore they don't want to go to the clinic anymore. That being said, they wanted to go see doctors. They valued face-to-face communication. They did want to go to a doctor and get prescriptions. And then what they also pointed out is that the context in which the clinic is set up is quite dissuading as well. Refugees are not given appointments when they go to healthcare clinics. So what that means is that they are going and waiting for over 5 hours with their children to see the doctor for 5 minutes. And this is quite a hassle for them. And also there are issues around miscommunication. The women reported that they feel like they can't ask their questions to the healthcare providers, and that the healthcare providers are not explaining to them their healthcare issues. And like I mentioned before, they do want to go see doctors. It's a big part of their health beliefs. And they said an effective doctor is a doctor that prescribes effective medicine. They do want to get medicine. We found out that medicine was vitamins, and they were calling it medicine. But it is something that is culturally rooted in them, that seeing a doctor is important. So then we started talking to them about how they're currently using technology to access healthcare. And they said that they are using technology a bit to access healthcare providers, but it's only in specific cases. And the cases are, if a doctor is from the private sector, then they feel more comfortable calling him because he's being paid and he has more time for us. Whereas when it comes to the public sector, they didn't feel that they weren't comfortable about it. They also found that pharmacists, in cases that aren't emergency cases, they can call them and the pharmacist would tell them what to do or what medication to go by. However, they found that nurses are quite hard to approach. A lot of them reported to us cases where they had confrontations with nurses and so on. So they said, we can't approach nurses at all. And another thing that they pointed is that if the face-to-face communication was positive the first time, then that means we feel more comfortable communicating with our healthcare providers using technology. So we looked at all this data and we thought, right, how do we build on it? What do we want? And then we just started discussing with them, what do you want? The first thing they told us is that they want an appointment system. But they did acknowledge that since the clinic isn't providing us an appointment system, and they perceive that the clinic will not cooperate in doing so, they started saying, well, we can use technology to organize our own appointments between us. They also talked about basically carpool Uber, if you look at it that way, and how if one of us does have access to transportation, then can't we all go organize each other to go at the same time, with each other to go at the same time in that transportation? Because some of the women were walking 2 hours while pregnant to go to a clinic. The most prevalent demands, I would say, is what they were asking for, were we want health messages and education. That we want people to give us this type of education so we can know what to do. However, they did point out that if it was a text-based type of education, it would marginalize a big part of the population because of the literacy, the language literacy problem. And then women that are residing in more remote, informal tented settlements who were walking that long distance said that I don't just want to have health messages pushed at me. I want to be able to ask my questions rather than having to go to the clinic just to ask a question. They did want a platform for two-way communication, but once we discussed that further, they'd say, oh, it would never work because healthcare providers don't want to communicate with us. They said, we're ready to use technology, we're ready to engage with them, but they do not want to engage with us. So how do we build on this, moving on with HCI, and design these different types of prototypes, deployments, to actually address the issues and address the issues that they expressed to us? The first is we need to look at the Sheikha-doctor paradox. It is an opportune moment to actually look at them and bring them together. So you have on one side a woman that they're very comfortable talking to, that they trust, but doesn't have any healthcare expertise. And then there's a doctor that they do want to talk to, but they aren't comfortable doing so, who has all the expertise. So how do we bring these two things together in order to improve their access to healthcare and their comfort in actually asking their questions? And also the fact that they already have peer networks and that culturally it's acceptable to discuss their health issues amongst each other. How can we use technology to leverage that? And I think what was quite inspiring for me personally was that the fact that they were saying that we are ready to use technology. We are ready to engage with healthcare providers, but they're not. Brings up the idea of how can we use technology to rebalance power and control when it comes to healthcare. Instead of waiting for the clinic to engage with them, can't they start engaging with the clinic using technology? And also our fieldwork showed that in the context of when it comes to refugees and the humanitarian system, any type of design that we want to deploy has to take in consideration the organizational and political barriers. We started working with one NGO, but then once we contacted the Ministry of Public Health, they requested that we work with another NGO. So being aware of these changing policies that are around the humanitarian system is quite important. And lastly, when we were there conducting the focus groups, we discussed all of these results that I presented to you, but a lot of the times the women just wanted to express their negative experiences. They want to tell someone of how they are experiencing healthcare as refugees. So the idea of if they want to express this, how can we use this constructively for health advocacy using technology? Let them put their stories together and say, this is the situation that we're at. This is why we are not accessing healthcare. So with that in mind, I think that we can start actually tailoring different types of interventions that would address these issues in a way that the population is comfortable in using and actually motivated in using. So thank you. I just want to mention that building on this presentation, we are organizing a SIG on how can HCI then move forward and build together as a community in order to aid refugees. Open for questions. Thank you.
Hello.
Hi.
I'm Anna Christian from the University of British Columbia. Thank you for your very nice presentation. I was wondering, there's actually been quite a bit of work done in various African nations about how mobile phones, especially in these healthcare contexts, just doctors and patients sending messages to each other, can have positive health outcomes. And these have been verified in actually randomized experimental trials. At least in BC, we've used it successfully for at-risk communities as well. And so I'm wondering, how are the needs of refugees, either different than just vulnerable communities in other places of the world? And how does the solution that you've specifically put forward differ from this previously existing literature?
Right. So when you look at that literature, and we have thought about designing such a trial, we saw that to actually do the initial engagement, they usually have to go to the clinic first time in order to register their number. Syrian refugees are even hesitant to register with the UNHCR because they're afraid that their data would be showing that they left the country during the war and what if they want to go back home. So the issue of how do we get their number in the first place comes up. So that's why we thought of going through the grassroots way of actually going with the community and building up together what they want. Another thing, and I think it's something that is becoming more prominent, is that the tension between refugee communities and host communities is showing even in healthcare. So you do find that that tension is what's dissuading the woman from going to the clinic. And healthcare providers who are overwhelmed with the volume of patients are simply sometimes feeling that we shouldn't explain to them. So SMSs, yes, would reach that goal of giving that education if they are literate. But would it then bridge together these communities? Would it actually make them feel comfortable to go and actually see a doctor when they really need to see a doctor? I had one participant who had 2 miscarriages because she just didn't want to go to the clinic. So it's past just health education.
So do you think the main difference is vulnerable populations are often integrated in the community, and that makes a difference in the response, whereas refugee populations are often seen as an intrusion into the community, and that needs different responses?
It definitely does make a difference, but even when you say integrating into a community, there's always tension that needs to be addressed in the initial phase of integration. And we're seeing this all around the world. So, and even in cases of ethnic minorities, it's showing up. So I think that HCI has such a big opportunity to start bridging this disconnect between communities and decreasing that tension.
Thank you.
Welcome.
Hi, so I just wanted to ask about your interview process.
Get close to the microphone.
Okay, hi. So my name's Kristen Williams. I'm from Carnegie Mellon, and I want to thank you for your talk. It's nice to hear about what's going on with the refugee situation. But part of my question was, during your interview process, you talked about creating these ideation cards in order to sort of ground discussion and facilitate them providing opinions on how technology might be designed to help. But then you pointed to these problems where the cards were sort of treated as not sacred, but they didn't want their children grabbing them, and so they didn't sort of effectively operate the way you might have hoped. And I was wondering if you could talk a little bit more about that, how you adapted during your interviews to accommodate that, or whether you think there were some limitations that were born out of that.
This was definitely a limitation. Because we went in and we only had assigned two of the researchers to go in, we didn't expect to have a focus group of 15 to 17 participants, plus the children. So we did find it very hard to keep on engaging with these artifacts. And we would encourage them, use the artifacts and pass them around, but they still felt that they don't want their children to ruin those. They even were protective over the recorder, because the children would try to grab the recorder in the middle of the tent that we were using to record. So I think moving forward, these ideation artifacts might be something that we want to make with them so that they feel ownership of them and feel that they can use them and build on them later on. And we're definitely going to have to divide focus groups from initially say, wait for everyone to come in and then divide and conquer, I'd like to say, because it was quite a chaotic way, and they just didn't want to ruin our stuff.
Thank you.
We have time for one more question. I would ask that the other person, I invite them to come back after the end.
Hi, I'm Amal from Carnegie Mellon, and thank you for that great presentation. I was wondering what you think about the implementability or practicality of technological solutions for refugees, because as I understand it, I think the UNHCR has a lot of bureaucratic red tape surrounding getting technology to refugees, and also the host countries oftentimes don't want the camps to become too permanent or luxurious.
Right. So here is a distinction that we always have a discussion in the Open Lab. In Lebanon, it's not as bureaucratic as you might imagine if you're trying to integrate technology for refugees within the NHS in the UK. So the way it works in Lebanon is that we already are collaborating with a university there that has really good ties with the NGOs, the local NGOs, and the UNHCR. And within the Middle East context, the UNHCR has shifted its policy in saying that don't come to us directly. Go through the local NGOs. We are supporting the local NGOs and go through the local NGOs, which is ideal because it's the local NGOs that are at the forefront when it comes to health, when it comes to livelihood and so on. So we've had a really positive experience engaging with NGOs, and they do want to start innovating more and move with the whole innovation within the UNHCR movement.
Great. Thank you.
Thank you.